Record. All right, everyone, good afternoon. Today we're going to do pathophysiology of the pulmonary system across the lifespan. So buckle up and away we go. So what we need to understand with respect to respiratory pathophysiology is the clinical presentation across the lifespan, because if you don't get the lifespan approach, you may mistakenly pathologize what is considered a normal adaptation. So we need to not only ask, what does disease look like, but how does normal function become abnormal? So we need to talk about the dynamics and the equilibrium from a healthy exchange of oxygen and carbon dioxide to shattering that disruption that you see in acute respiratory distress syndrome or the slow throttling of an airflow effect in chronic obstructive pulmonary disease. And I'm also going to discuss with you how age, pregnancy, chronic insult affects overall pulmonary physiology. So we're also going to apply pulmonary function testing to guide clinical decision-making in primary care primarily. And we'll talk about pulmonary function test as more than just a number printed on a chart. It's supposed to tell you obstruction, restriction, or impaired gas exchange. So how do we interpret spirometry, total lung capacity, things like residual volume, diffusion, lung capacity? All of those numbers are guides. They're not absolute. And so they're going to change over time, and you're going to interpret for age, race, and height and sex. We're also going to recognize when common pulmonary conditions require a specialist referral or acute care intervention. You need to ask yourself, what threshold demands this escalation? And when does shortness of breath demand expertise of like a pulmonologist, or when do you need to go to the ER? This is not going to be as clinically focused, but you will see what the numbers look like, and you'll have an idea of which way we're heading. We're also going to take a look at evidence-based approaches to look at how we manage things like, why do we do the things we do? Why do inhaled corticosteroids benefit something like type 2 inflammation and asthma? Or why do we recommend smoking cessation as the only intervention proven to slow COPD progression? We're going to integrate this across the lifespan so we can consider what the pulmonary assessment and treatment planning might look like and say the neonate, the child, the middle-aged adult, the elderly patient, the pregnant woman. How does respiratory physiology shift with each phase? And what do we mean by normal in pulmonary physiology? And how does that pathology disturb the state? Let's see what's in the chat box here. Can you please turn on the closed captioning? I see that it is turned on. Let's see here. Okay, so let's talk about pulmonary pathophysiology. So how does oxygen transport, gas exchange, and airway mechanics become deranged in presenting as dyspnea, cough, or hypoxia? What mechanism might explain the patient's respiratory distress? Is it obstruction, restriction, vascular impairment? Is the process acute or chronic? And how does the story differ? Got to pop up here. Subtitles not available right now because the speaking voice is too quiet. Okay. And how does the story differ between child, adult, and older adult? And why do we choose, say, bronchodilators for asthma or corticosteroids for autoimmune inflammation or antibiotics for pneumonia? The pathophysiology at the cellular pathway, the mediator cascades, and the mechanical alterations, these are the things that will justify your clinical decisions. When does an unexplained hypoxemia or a refractory respiratory distress demand escalation? And what are the red flags and what are the thresholds that you must never ignore? So before we can diagnose or treat or even suspect disease, we first have to understand what normal looks like. So let's begin with the simplest question. How does the healthy lung work? It oxygenates blood and removes CO2, yes, but that's only because of ventilation, perfusion, and diffusion. And this is balanced across about 70 square meters of alveolar surface. That's 70 square meters is about the size of a tennis court, all bundled up into the alveoli, packed into your chest. That's how much we're talking about in terms of surface area. The body achieves this through synchronized effort between three mechanical systems. You have the lung parenchyma and the airways, the chest wall, and the neuromuscular pump that controls all of this. So why is this important across the lifespan? Because respiratory physiology is not static. A newborn may have a compliant chest wall. An adult may have optimized alveolar recoil, and an older adult stiffened thorax, and that represents different trade-offs between elasticity and stability over time. Compliance is high in infants, and it's also high again in someone with emphysema. These are two extremes that are meant to illustrate how this pathology is playing out. So in aging, for example, you may lose elastic recoil, but you gain residual volume. So even under normal older lung function, there's a disadvantage. So how do you measure this system in practice? Well, the way we do this and what we're really looking at is pulmonary function testing. Really, we're looking at what can these lungs do. And we concern ourselves with FEV1, FVC, and FEV1 VC ratio. So our window into mechanical performance is the pulmonary function test. This tells us where airflow is limited and how much reserve is left, and whether the problem lies in obstruction, restriction, or gas exchange. But here's the key: the number never stands alone. They only matter when interpreted in the context of age, effort, and expected physiology. Finally, why does this matter in terms of your decision making? Because every clinical choice, whether it's in primary care or ICU, depends on understanding where in the system the disturbance is happening. So is it a mechanical problem, like, say, airway narrowing or chest wall rigidity? Is it a gas exchange problem, like diffusion impairment? Or is it a control problem, like, say, neurological hypoventilation? Establishing this framework early is going to help you decide what belongs in outpatient follow-up versus what you need to do acute care with. So it's the physiology that's guiding how you approach the patient. So what does it mean for a lung to be normal? This is not a static concept. It's moving, and the target is shaped by things like age, posture, gravity, pregnancy. They call this the miracle of respiration because it lies in this perfect balance of the alignment of ventilation, which is abbreviated V, and perfusion, which is abbreviated Q. So when we refer to the VQ being out of sync, what we're really talking about here is this gas exchange that is faltering. So even healthy lungs on the edge of this mismatch are occurring. The lung apex gets more air than blood, while the base gets more blood than air. And gravity is this underlying force, but in the end, it comes out to a near perfect match. So the top may get less blood, the bottom may get less air, but overall, the body is matching ventilation to perfusion. Optimal gas exchange depends on matching ventilation and perfusion in each individual alveolus. But the match is never quite perfect, obviously, because even in health or regional differences can arise from how the lung hangs in the chest cavity. The bases are heavier with blood than the apices are lighter, and they're overventilated. But together, it comes out to a pretty good ratio with respect to gas exchange. Now, this 70 square meter thing here, that's working surface of life, essentially. This is the complete alveolar capillary membrane network. It's only 2 cells thick, and it separates air from blood by the distance of microns. That's how fragile this window is. Now, how do oxygen and carbon dioxide make this journey? Well, it's not by force, but it's by gradient. So oxygen moves from a higher partial pressure in the alveolus to lower in the capillary, and CO2 moves the other way. So this exchange is perfusion limited. It happens faster than blood can flow, and only when the membrane thickens in cases like, say, fibrosis or circulation races, or as in things like exercise, circulation's higher, does this diffusion become a limiting step. So this is really what we're talking about: cardiopulmonary adaptation and capacity building. So acutely, you're going to feel short of breath because it can't keep up with this matching, but as you get better, it should improve. Another variable we need to consider is what effect does age play? So in the same newborn, pregnant woman, 90-year-old, for example, in pediatrics, the lungs are still writing this blueprint. The alveoli are fewer, airways are narrower, the chest wall is softer, compliance is high, but that means there's less structural stability. So there's a higher respiratory rate in children in order to maintain ventilation. In pregnancy, physiology adapts to sustain two lives. The diaphragm rises, there's a functional residual capacity that falls. The tidal volume increases, they hyperventilate, but that's a physiologic normal adaptation. That in turn, if you hyperventilate, will lower your CO2 and drives off the fetal gas exchange. So if you're hyperventilating, blowing off your CO2, what might you guess is normal in a pregnant person with respect to their blood gas? Think about that, and we'll come back to it later. Blood gases were on the midterm. They're likely coming back for the final. In geriatrics, though, the opposite is true. So what happens is elastic recoil is waning. There's small airways that close sooner, and diffusion lung capacity is declining. So FEV₁ falls predictably with each decade of life, not as a disease, but this is the effect of time on the tissues. So let's take a look, and then I'll show you a chart that summarizes all this. Let's take a look here at respiratory changes in pregnancy. So progesterone levels rise sharply from about 25 to 150 nanograms per milliliter. This hormone doesn't just affect the uterus, it also resets the brain's respiratory center. So pregnant women become more sensitive to carbon dioxide, so they breathe a little faster and deeper. So that's why there's a normal mild respiratory alkalosis is normal in pregnancy. Progesterone also causes smooth muscle relaxation, which means bronchial dilation, but at the same time can lead to nasal congestion. So their noses are stuffed, they're breathing more with the mouth gaping open, and the lungs are trying to open, and so there's increased mucosal edema due to the progesterone. Mechanically, what's happening is obviously as the uterus grows, the diaphragm is moving up about 5 centimeters as the uterus continues to grow. This elevation, obviously, you know, is going to increase intra-abdominal pressure and pushes on the thorax, which widens that subcostal angle. It can go as wide as about 100 degrees. And the rib cage literally will flare out. That allows the chest wall to expand, even though the diaphragm has less room to move. You can see how this compensatory mechanism is trying to keep mom and baby alive. Now, how do the volumes change? Well, minute ventilation rises by about 50%, mostly because there's an increase in tidal volume, not respiratory rate. Functional residual capacity and expiratory reserve both drop. There's just less space at the end of respiration, but total lung capacity, all things being equal, stays about the same because of the chest wall expansion. Now, something else happens in terms of gas exchange. The increased ventilation lowers the maternal PaCO2, that's partial pressure CO2, to about 27 to 32 and slightly raises the PaO2 to 106 to 108. The result is mild, compensated respiratory alkalosis because the pH is going to be around 7.44. Remember, The blood gas is compensated if your pH is 7.35 to 7.45, right? That's how you can tell compensated from uncompensated. Now, the kidneys adjust by excreting a little more bicarbonate because we're trying to maintain good acid-base balance. So what you're seeing in pregnancy is this finely tuned respiratory shift. The mother breathes more to deliver extra oxygen to the baby, even while the lungs have less physical demand to expand. Well, what happens now in the aging lung? Well, these changes are gradual, they're predictable, but they're physiologic. And they can easily trip into pathology when things happen like compounded by illness and inactivity. The lung scaffolding is this elastic fiber, and this gradually breaks down, and collagen becomes stiffer. That means that the lung becomes more compliant or stretchy, but less capable of snapping back during exhalation. Air gets trapped, and expiratory flow slows. So, this is why older adults may have a prolonged exhalation of residual volume in the lung, even without COPD. So someone with COPD may look like a fish on land because that exhalation is so far out. Diffusion capacity also declines with age. Starting at around age 30, alveolar surface areas begin to shrink. And about 15 to 30% reduction can be expected by the time you're 70 years old. The capillaries regress along with it. When it shrinks, then less perfusion is needed. So there's less contact between air and blood. Resting gas exchange often will remain stable, but the reserve is gone, and that's key. They have less physiologic reserve as they age. So during exercise, the PaO2 is going to drop more than it used to. So they just can't keep up. There's less surface area to allow for this gas exchange. Another thing to keep in mind is immune function changes as you age. What do I mean by that? Well, ciliary motion slows down and mucus thickens, and the alveolar macrophages don't clear pathogens as effectively. And then there's this exaggerated or blunted inflammatory response as the result of this higher infection rate and slower recovery from things like pneumonia and bronchitis. It's just not moving. That mucociliary escalator is not able to clear whatever's been inhaled. From about age 25 onward, FEV₁ is dropping about 30 milliliters per year in non-smokers, and it's almost double that in smokers. So we start to basically die at 25. It's the best 25 years. After that, we're all doing a Hail Mary defense. So this is the normal curve of aging. But it means that older adults operate closer to the threshold where small stressors like a mild viral infection or heart failure can cause noticeable dyspnea. So the key takeaway is this: the aging lung is not failing, it's adapting, but with less elastic recoil, less diffusion capacity, and slower clearance. It lives with a thinner margin of safety. And that's why preventative care in the elderly and early interventions matter so much more in terms of geriatric respiratory management. So when you say PFT, what do we mean? What are we measuring? Well, here you go. When should you order this test? And what exactly are all these numbers telling us here? Well, spirometry, here are the basics. And also, I don't do office spirometry. If I need a PFT, I send them to a PFT lab. I get a pulmonary interpretation. They write me a lovely report, but they have the nerve to throw all these numbers and letters on there. So I'm going to help you try to navigate what this report might mean. So at its core, spirometry is measuring air flow. And there are some values you need to pay attention to. You have FEV₁. This is how much air the patient can forcefully exhale in 1 second. And then you also have the FVC, the functional volume capacity. This is the total volume exhaled after a deep breath. Now think about what I'm telling you in terms of what has to happen to get good numbers. FEV₁ and the FVC ratio, this is the proportion of the air expelled in that first second relative to total. A low FEV₁ and FVC ratio points towards an obstructive picture. Like what? Think asthma, think COPD. A normal high ratio with low total lung capacity, on the other hand, tells you there's restriction in terms of things like fibrosis. And I'm going to show you more examples so you'll get this. Or fibrosis, neuromuscular weakness, those are restrictive lung diseases. So automatically what you're doing is you're forming categories for pulmonary pathophysiology by saying, is this an obstructive or a restrictive lung disease? That's already the categories you're hoping to form in your mind. So a complete study, though, goes beyond simply airflow. This is why I send for the PFT, because you can do office spirometry and get those first few numbers. But the complete PFT is going to look at things like lung volume, total lung capacity, residual volume, air functional residual capacity, which is what FRC is. These show you whether there is air trapping or reduced expansion. There's another abbreviation called diffusing lung capacity, and it's abbreviated DLCO. What this is telling you is how well gases move across the alveolar capillary membrane. So a low DLCO can indicate something like emphysema, interstitial lung disease, or even anemia, if you think about what's necessary for oxygenation to happen. So when do you order these? Well, you use PFTs when symptoms don't fit the usual picture, when there's unexplained dyspnea, chronic cough, or wheezing. There's also critical because these will help you track known lung diseases. So it helps you assess progression or decline over time in response to different therapies. Now, here are some limitations you need to keep in mind. Because of all this stuff you're doing, I need a very agreeable, compliant patient, or they need to be intubated and sedated. But even then, you have to deal with that. So these tests depend on effort, technique, lip tone, if they quit early, how variable the coach was. The coach is that respiratory tech who's cheering them on. Come on, you can do it. Blow hard, blow fast, push, push, push. That's the coaching. If the coaching is like, you can do it. Come on, do it. I don't care. I get paid whether you blow or fail. Here we go. If you have that mentality, you may get bad results and you have to overtreat the patient. So interpretation must always be adjusted for age, sex, height, and ethnicity, because normal lung function is not universal. So PFTs are not so much about catching the disease, it's about characterizing how sick are you really? That's what we're doing PFTs for. Now, here's the table for you across the lifespan, so you have something to refer to. So this table helps put pulmonary function values into perspective. So when you interpret a PFT, you're always comparing a patient's number to a predicted value. That predicted value is adjusted for age, sex, height, and ethnicity. Okay, so it's interesting when you're putting someone, say, on a ventilator, do you put them on a ideal body weight, tidal volume, or do you put them on an actual body weight, tidal volume? Well, ideally, you do ideal body weight, but you also then have to do some sort of voodoo and witchcraft to overcome for the fatness on the body that's raising their BMI that requires more force from the ventilator to blow those lungs open. But if you put too much force in there, well, then you can cause barotrauma. But if you don't move the lungs at all, then you get what? Atelectasis, consolidation, and poor ventilation. So somewhere between ideal body weight and actual body weight is going to become the recipe for what the tidal volume needs to be. And that's why pulmonary function tests are a number you get adjusted for age, sex, height as to what is predicted. So let's look at pediatrics here. Children have a natural higher FEV₁ to FVC ratio. Usually it's above 85% because their lungs are small, but their airways are relatively large. Both FVC and FEV₁, they rise steadily as they grow, typically landing somewhere between 80 and 120% of predicted values once adjusted for height because they grow fast. And total lung capacity, diffusion lung capacity, and functional residual capacity, all of these increase as that thorax expands. Well, think about that. What happens as you get older? Well, if you have osteoporosis, osteopenia, that thorax may no longer expand, it may contract. And how does that play into what the PFT should be? So that's why that number is adjusted. So where you might see a test question would be when we discuss, say, osteoporosis, and I like to bring in some pulmonary function, and you think it's about bone, but really it's about pulmonary. And so we're bringing the two conditions together. That's why the final is cumulative, by the way, because it all relates. In, say, a healthy adult, 19 to 64 years old, healthy adults will have an FEV1 to FVC ratio that is stable around 70%. Now, both FEV1 and FVC will stay within about 80 to 120% of the predicted value. The TLC average is about 5 to 6 liters in men, total lung capacity, and 4 to 5 liters in women. And the diffusing lung capacity remains stable, assuming they're not smoking and there's no underlying lung disease. Now, with respect to the elderly, we typically see a predictable decline of FEV1. It drops about 30 milliliters a year after age 25. Or have I heard that before? And the FEV1 to FVC ratio often falls to about 65 to 70% of predicted. And the FVC and diffusing lung capacity also trends down. And this reflects that loss of alveolar surface area. Total lung capacity tends to remain stable, but the FRC rises slightly because of air trapping. There's that prolonged exhalation time. And finally, pregnancy here, the lung mechanics change, but overall capacity stays about the same. The diaphragm is elevated, and the FRC is about 10 to 25%. And the diffusing lung capacity also increases due to this enhanced pulmonary blood flow. Normal is not one number. It's that moving target depending on developmental stage, age, and physiologic state. So baselines are helpful, and keep in mind, we're always working against a predicted number. You don't need to memorize these. You just need to conceptually understand what is FEV1, what is FVC, what does that tell you? So let's take a look at how you might interpret a PFT test. So when we look at pulmonary function tests, the key question you need to ask yourself is the problem getting air out or getting air in? This is the real crux of the matter here. This is the essence in differentiating obstructive from restrictive lung disease. So how do you do this? What you do is you take a look at FEV1 and FVC. If the value is below 0.70, this is the definition of an obstructive lung disease. It means that the patient can inhale normally, but exhalation is slowed. The airways are narrowed or collapsed. Now, if the ratio is normal or high, you need to think restriction. The lungs can't expand fully, so total capacity and flow are both reduced proportionally. In obstruction, the FEV1 and FVC ratio is low. The FVC may be normal or slightly reduced if the air trapping occurs. The total lung capacity can be normal or increased, and patients may have hyperinflated lungs. The diffusing lung capacity will often fail, especially in situations like emphysema or where the alveolar walls are destroyed. I think inhalation burn. In restrictive lung disease, FEV1 and FVC will stay normal or slightly elevated. The FVC and total lung capacity will both drop. Diffusing lung capacity will vary, but it's low in conditions like interstitial lung disease, normal in chest wall restrictions. So what is this diffusing capacity of the lung for carbon monoxide? Let me explain that, DLCO, because that's what that stands for. What that is measuring is how efficiently gas moves from the alveoli into the pulmonary capillary blood. What they do is they give a small amount of carbon monoxide, and it's used in the test because it binds strongly to hemoglobin, more so than oxygen. It has a higher affinity for hemoglobin bonding. So this is like a really sensitive detection gas transfer across alveolar and capillary membrane. And that's why we use carbon monoxide. So that's how we're measuring impaired gas exchange. Now, let's take a look here at this bronchodilator reversibility testing to give you the next clue as to how to interpret this. So FEV1 improves by 12%. And at least 200 milliliters after a bronchodilator, this obstruction is thought to be reversible, and it's most consistent with an asthma diagnosis. A small subset of COPD patients, about 10 to 20%, will show partial reversibility, but the improvement is rarely complete. It's not as robust. So when you interpret a PFT, follow this order. You're going to look at FEV1, FVC ratio. That will tell you obstruction versus restriction. Check the total lung capacity to confirm restriction or hyperinflation. Review the diffusing lung capacity to determine if the gas exchange surface is intact. And then this will keep you from overinterpreting a single number. You want the whole picture to make sense to you. So this slide's going to help bring it all together for us here. We're going to recognize obstructive versus restrictive physiology on the PFT. So we're going to start on the left column here with obstruction. This is the hallmark here of airflow limitation. The patient can take air in just fine, but has trouble getting it out. Notice the FEV1 drops sharply because exhalation is slow and incomplete. The FVC can be normal or slightly reduced. Take a look at the ratio. It falls below 0.70. That's the diagnostic cutoff for obstructive lung disease. The total lung capacity here is often normal or even increased due to air trapping or hyperinflation. The diffusing lung capacity falls when the alveolar walls are destroyed, like in emphysema, but it could be normal in asthma. And pathophysiologically, the obstruction reflects airway narrowing, a loss of elastic recoil, which is what you're seeing in something like asthma, COPD, bronchiectasis, bronchiolitis, etc. Now take a look on the left side there of your right side of the screen there, the restrictive lung disease. Here, the tissue is limited expansion. So the issue in the lungs cannot fill normally. Both FEV1 and FVC are reduced proportionally, so this ratio will stay normal or even slightly increase. The total lung capacity is your clue here. It's markedly decreased. The diffusing lung capacity will help determine the cause. If the diffusing lung capacity suggests an interstitial process like fibrosis, that's when it'll be low. If you have a normal diffusing lung capacity suggesting like an extrapulmonary cause, like chest wall or neuromuscular, what else might you see there? Well, when I was in the military, we had a lot of blast injuries, and so you might get a circumferential burn around the chest. Well, if the skin swells so much so that it restricts the chest wall from being able to expand, we might have a normal diffusing lung capacity, but something is markedly reducing my total lung capacity. It's not in the lungs, it's outside. There's no room to expand. So those are the people that you give a fasciotomy to put release cuts so that the chest has room to expand. It's life-saving in that respect, because you can intubate and blow air all day long, and that skin, that circumferential, is going to swell. It's going to keep the chest from being able to receive that airflow. Restrictive patterns will come from things that make the lungs stiff or small. Think fibrosis, sarcoidosis, scoliosis, neuromuscular weakness, pleural thickening, circumferential burn. Those are the restrictive lung disease pathologies to think about. So if the FEV1 to VC ratio is low, it's obstructive. Less than 70, it's obstructive. If it's normal, but the TLC is low, then it's restrictive. If the diffusing lung capacity is reduced, it's a diffusion problem. If it's normal, it's a mechanical problem. So in clinical practice, you're always thinking obstruction cannot get air out, restriction cannot get air in. You got that? Okay, good. So let's talk about okay, welcome to the class, Jake. Okay. All right, let's talk about the upper airway collapse that happens in obstructive sleep apnea. So each time this happens, the airflow stops, oxygen drops, and the brain briefly wakes up the body just enough to reopen the airway, and this cycle will repeat itself over and over and over and over again, sometimes hundreds of times per night. So the pathophysiology here is intermittent obstruction leads to hypoxemia, which triggers microarousals. over time, this constant burst of sympathetic activation drives the blood pressure up, drives the heart rate up, drives up systemic inflammation. And this is why obstructive sleep apnea is linked to conditions like hypertension, arrhythmia, insulin resistance, and stroke risk. So this is why you need to make sure that this is effectively treated. And in order to treat it, you have to identify it. So how do you identify it? Well, think in the adults, this classic triad: loud snoring, witnessed apneas, and daytime sleepiness. The problem is all the single people who sleep alone don't know if they're snoring because they're not necessarily waking themselves up. Patients will often report things to you like morning headache, poor concentration, irritability, or falling asleep during the day. Now, I tell my psych students, please pay close attention to this and remember to rule out an underlying medical condition, lest you just give them an SSRI for their poor concentration or irritability. In children, the picture's a bit different. So you may notice things like hyperactivity, poor school performance, bedwetting, and mouth breathing. Many get misdiagnosed actually with ADHD when the real issue is this obstructive sleep apnea. So you want to make sure this is dealt with. The problem is good luck trying to get a school-aged person to wear their CPAP mask. I can't even get adults to do it. Sometimes they'll do like a tonsil adenoid surgery if that's the issue. Sometimes you can do watchful waiting, especially if there are no symptoms that are bothersome. The airway and head may grow enough to accommodate the tonsils and adenoids. That happened to my kid. He flunked his sleep study. We realized we were sharing a room, and my God, he's snoring. He stopped breathing in the middle of the night, and he comes back, and we only knew it because we're sleeping in the room with him on vacation. So we quickly got him into a sleep study in which I proceeded to snore through the whole thing, and he could not sleep, it turns out. And so much for that idea, but he did qualify. We just waited for his head to grow, and he didn't need to have anything done. So the screening tools here include things like the Epworth Sleep Scale. There's a stop-bang questionnaire, simple but sensitive for detecting risk. The gold standard, though, for doing obstructive sleep apnea is the polysomnography. That's the overnight sleep study that measures the apnea-hypopnea index. If you have 5 to 15 events an hour, that's mild, 15 to 30 moderate, more than 30 per hour, that's considered severe. First-line management is CPAP. You want to avoid sedatives and sedative hypnotics. Sometimes you may give a stimulant during the day. Obstructive sleep apnea is not just snoring. It's like a chronic condition of repetitive hypoxia and sympathetic overdrive. That's what's reshaping the cardiovascular and metabolic health over time. So you want to restore this. There are some behavioral things you can do, but that's beyond my purview here today. All right, let's talk about this here, pulmonary embolism. So this is one of the biggest emergencies, and if you don't look for it, you might miss it, and it's kind of a big deal because it can be fatal. You remember when we talked about clotting in the hematology lecture about Virchow's triad? Well, here it is again. Hypercoagulability, venous stasis, and endothelial injury. This is when a thrombus will form, most often in a deep vein of the leg and pelvis. And then it breaks loose and travels to the pulmonary artery. The clot obstructs blood flow, and that's what creates a ventilation-perfusion mismatch. Air reaches the alveoli, but the blood does not because of the blood clot. That results in the hypoxemia despite having normal ventilation. In the old days, we used to do this thing called a VQ scan where you inhaled this nuclear isotope and we would see the air enter on this nuclear medicine test to see if there is a matching of perfusion to what you have inhaled. You have to be quite awake to do that. You have to be with the program, have good lip tone, etc. Now we just do a contrasted CT scan, but we have to make sure we don't kill your kidneys in the process. That is the gold standard. So in a massive PE, the obstruction increases pulmonary vascular resistance, and that can strain the right heart. So you can actually have a PE with right heart strain. That's why we do an echo in people who have a PE diagnosed, because we're looking for some RV obstructing the outflow. So if RV output falls, they can go into cardiogenic shock from the pulmonary embolism, and depending on the size and the obstruction, it can be quite sudden and lead to death. So what does this look like? The most common presentation is sudden onset dyspnea. That happens in about 70% of patients. The other major one is pleuritic chest pain. I diagnose over the telephone sometimes. I have pain when I take a deep breath. I'm breathing faster. I'm tachycardic. I'm hypoxic. Sometimes I'm spitting up blood. That's a 911 to the ER. You always want to look for signs of DVT, leg tenderness, and warmth. And then if they have the tachycardia, hypoxemia, tachypnea, that's the person you're going to diagnose the PE in. Now, the treatment's basically the same. Anticoagulation with the direct oral anticoagulants if they qualify. But the reason we would investigate the PE is if it starts to cause things like downstream effects. The major risk factors haven't changed. Recent hospitalization, prolonged immobility, surgery, malignancy, history of prior venothrombotic events, thrombophilias, hormonal oral contraceptive, and still smoking, but oral contraceptive de novo is also a risk factor, hormone replacement therapy, and in men get hormone replacement therapy too. Turns out, ageless man and low testosterone for everybody. They can get it online. They're on testosterone. They don't have their levels checked. Their hematocrit soar. They set the stage for a clot to form. So yes, men too are now on hormone replacement therapy. So you have to consider them in your differentials of pulmonary embolism. If their levels are normal and the hematocrit's not high, we can't blame the testosterone. Okay, so how do you approach this? Well, you've heard of the Wells score. The Wells score is just a probability scoring tool. You can pull up your MD Calc app, and depending on the criteria you enter there, the higher the score, the higher the risk. If the suspicion is low or moderate on this checklist tool in your phone, you can do a D-dimer. The problem with a D-dimer is you have to age adjust it, meaning in old people, a D-dimer is going to be high. So what you want to do is say age times 10 micrograms per liter. That's the adjustment factor. Not going to ask you that, just know that one exists. Now, if the suspicion is high or the D-dimer is positive, then you want to go to CT pulmonary angiography. That's the gold standard. A VQ used to be used if the CT pulmonary angio is contraindicated. So that is a big to-do emergency. Okay. So let's move on now to sarcoidosis. Now, sarcoidosis is a condition that sits at the crossroads of, say, immunology and pulmonology. This is an inflammatory disease that can quietly affect almost any organ. It's a big deal, though, when it affects the lungs. So sarcoidosis is an immune-mediated condition that forms what they call non-casseting granulomas. This is a tight cluster of macrophages and lymphocytes that form in response to some unknown trigger. So when you see ground glass granulomatous syndrome on your X-ray report, we're normally either looking for sarcoidosis or tuberculosis. Those are the two things where the macrophage encapsulated the invader, and now it's caused this appearance in the chest X-ray. We don't normally understand this antigen, but it's thought to arise from some sort of environmental or infectious exposure in some genetically susceptible host. The lungs and the lymph nodes are most often involved, and the lymph nodes will have what they call this hilar lymph node fountain-looking appearance. The process can affect any organ, though, so it's like an over-organized immune reaction, and the body's trying to wall it off. So there's no true infection to contain here. The pulmonary findings, about 90% of patients will have what they call bilateral hilar lymphadenopathy. That's like the hallmark chest X-ray finding. You may see interstitial infiltrates. You may see reticulonodular changes. Many are asymptomatic, but many people will present with this cough that won't go away, dyspnea or chest discomfort, and it's really only a matter of time before it's affecting their pulmonary function. They may have had it for years, likely they have, it's formed a granuloma, and then they come in with symptoms. So these patients can look like they have asthma or early interstitial lung disease, but the X-ray is the clue. It's that bilateral hilar lymphadenopathy finding. So there can be some extrapulmonary involvement. Sarcoidosis is systemic in nature. So you might see like skin shows erythema, nodulosum. The eyes might have uveitis. The heart can have conduction abnormalities. The nervous system might have like a facial nerve palsy. So here's the deal. One time, 14 years, 15, I don't know, 2006, 7, whenever that was. I was about to be deployed, and I had the worst headache of my life. The problem was it was in July. And you know what happens when you go to your primary care provider in July and they say worst headache of your life, and they say go to the ER where every resident and their mother just graduated the day before, and now we call them doctor, and they want to try all their new tricks and tools. Well, I knew better because I'd been in healthcare 15 years at that point. I was not about to go. And then I developed shingles on my head, and it started to invade my eye, and it affected my vision. Like a good prescriber, I took care of that myself. But what did I have? I had uveitis. I had this weird rash. I had all these crazy symptoms, and the doc was like, oh, let's look for zebras. Might it be sarcoidosis? Well, you have granulomatous in your lungs. Oh, my goodness. Well, what are we going to do? We'll check an ACE level. We don't know what to do with that, but okay, go ahead. And he wanted to go down this path of sarcoidosis. I'm like, wait. 3 months after I moved to New York, I developed latent tuberculosis because I rode the subway and probably someone popped off their vent in the medical ICU, and I probably breathed in some tuberculosis. I did do 9 months of INH, so I don't have to really worry about that. But suffice it to say, you may have a lot of these symptoms, uveitis, the headache, the visual changes, the granulomatous findings, and you may indeed have it. The question is, if you don't have pulmonary symptoms, why are we going after this? So this is kind of a hard one to diagnose. You want to put the picture together. It affects many systems, but just because those systems are affected, it does not mean this is your condition. In short, if you're worried about sarcoidosis, you start with the chest x-ray. You look for the classic bilateral hilar lymphadenopathy pattern. The ultimate test is going to be a tissue biopsy to show these granulomas, especially if the presentation is atypical or extrapulmonary. Labs may show an elevated ACE level and elevated calcium. You may have abnormal liver function. I had none of those. And then that's how you exclude infection, especially tuberculosis. And the other big one, of course, is always malignancy. You don't want to miss it. The good news is most cases will resolve spontaneously in 1 to 3 years. So this is like symptomatic support. If it doesn't develop any other systemic problems, you don't need to worry about it. The treatment is going to be corticosteroids. Sometimes methotrexate or hydroxychloroquine, and it's a diagnosis of exclusion, by the way. So there's no 100% other than you get to the biopsy. And they have to put the picture together. Okay, so let's take a look here at primary care decision points. So what you're going to do to decide if your problem belongs in primary or acute care is you always want to start with the red flags. Any red flag, pulse ox less than 90% on room air. That means the compensatory mechanisms are failing. This is not a watch and wait situation. This is go to the ER situation. If they have hemodynamic instability, hypotension, tachycardia with altered mental status, that implies a respiratory issue. This is not sit in the office. This is go to the ER problem. If you have respiratory distress despite interventions, like say, I have asthma, you've given the bronchodilator and the steroid, and they're still struggling to breathe, go to the ER problem. This is not an office problem anymore. You've exhausted your resources and you want to be in the right place should you have to intubate. If you have new asymmetric chest findings, right, you want to think of those acute things like a pneumothorax, effusion, consolidation. These require imaging, likely going to the ER for that, because if they find it, they're going to need that acute intervention. What can you manage in primary care? Things like asthma, mild to moderate, responding to initial treatment. The peak flow gets better. The COPD is stable. They're at a gold stage 8 or B, and we'll talk about that in a minute. But these patients are chronic and uncomplicated. Community-acquired pneumonia can be safely managed primary care. Acute care is when you have things like the hypoxia and those clinical symptoms with the tachycardia and constitutional findings. Don't sit on that. So what do I want you to take from this portion? The lungs maintain your gas exchange through the balance of ventilation perfusion. Gravity creates this natural VQ mismatch. The apex ventilates more, the base perfuses more. Gas transfer occurs by diffusion. You're moving oxygen and carbon dioxide along these pressure gradients across the alveolar capillary membrane. There's age variations to normal pulmonary physiology. Children are more compliant chest walls. They have higher respiratory rates and low reserves. Pregnant women, on the other hand, the diaphragm is climbing up in the chest. The FRC is down by 10 to 25%. Tidal volume is up, and there's mild respiratory alkalosis. The elderly, they have reduced recoil, increased residual volume, and reduced diffusing lung capacity. Across all age groups, just pay attention to the adapting physiology here. Now remember, the pulmonary function test, spirometry measures what? Airflow, FEV1, FVC, FEV1 to FVC ratio can be done in the office. When you get to pulmonary function testing, formally that then includes total lung capacity, residual volume, FRC, and the purpose of that is to distinguish obstruction, air trapping, from restriction, reduced expansion. Total lung diffusing capacity evaluates the alveolar capillary efficiency. Carbon monoxide is used because it binds to hemoglobin more effectively than oxygen, and that's going to reflect that how sensitive that exchange can be. Okay, and so what is the definition on a PFT of obstruction? The FEV1 FVC ratio is less than 0.7. So you might see a pulmonary function test, and I will tell you the FEV1 FVC ratio is, say, 0.65, and you're going to say this is most construction. It's consistent with what? Obstruction, restriction, vascular issue, or hypoxia. And then you're going to know if it's less than 70, that's obstruction. So then the next step you'll do is look at the total lung capacity. If it's low total lung capacity, think fire around the chest, I can't expand, it's low, that means it's a restrictive lung disease. Total lung capacity is low, that's a restrictive lung disease. And then you want to evaluate the diffusing lung capacity. That will tell you if it's alveolar or a vascular problem. Okay. Okay, I think we're going to take a break for 5 minutes now, and then we'll come back and we'll continue with obstructive lung disease and really get into the nitty-gritty for asthma. Let me pause the recording. All right, let's talk about now asthma. So what defines asthma is not a single disease, but this is a syndrome of airway hyperactivity and chronic inflammation with multiple phenotypes. So when we talk about asthma pathophysiology, the unifying thread is the type 2 inflammation, the eosinophil-driven IL-4, IL-5, IL-13. Where have you heard that before? In the first lecture. This is the pathway that leads to airway edema, mucus hypersecretion, and smooth muscle hypertrophy. That's why we started this whole thing with inflammation, edema, and fluid, because these themes will keep coming back, because that's how you die. So when these things surge, we want to know, how do you die from everything? And so when you start to see these inflammatory markers and cytokines start to flare up, you can now recognize death is coming. I should do something. Okay, so over time, these processes will cause something called airway remodeling. The thickened basement membrane, its fixed narrowing, and a shift from a reversible obstruction to a partially irreversible disease process. And across the lifespan, pediatric asthma is often atopic, driven by allergies, eczema, environmental triggers. So it's not uncommon if a child has eczema, you may also coincidentally have asthma. It's the same inflammatory cytokines that are flaring up here. Children have smaller airways and make even mild swelling clinically significant. This is why they present with wheezes and coughs from viral infections that an adult can easily tolerate. Adults have bigger airways. In adult asthma, it can be allergic or non-allergic, but it's often linked to occupational exposure, obesity, or hormonal changes. Now, some adults will develop a late onset eosinophilic asthma with fewer allergic markers, but more airway remodeling. And then in the geriatric population, this can often overlap with COPD, which is often what we will call asthma COPD, overlap syndrome. But they often will call it asthma COPD. And you're like, well, is it asthma or is it COPD? Yes, that's not helpful. I understand, but that's really what's going on because of the remodeling. So this patient may have less reversible, obstructive, and lower perception of dyspnea, increasing their risk of like an underdiagnosis and delayed treatment because they're like, oh, it's COPD, this is normal decline. No, you might want to try that bronchodilator. It might actually work for them. So diagnostic testing builds on what we've covered so far. So PFTs will show variable obstruction. The FEV1 FVC ratio will be less than 0.7, and this improves by at least 12% and 200 milliliters after bronchodilator use. The biomarker is the eosinophil count, and you're looking for a fraction of exhaled nitric oxide. You can also look at IgE levels, and they help you identify this type 2 inflammation. This is like a useful biological therapy selection marker. If you want to go down the path of like a monoclonal antibody for this, this is what we're doing. Now, let's look at some evidence-based management approaches. We're going to discuss the GINA 2024 guidelines, and we'll talk about inhaled corticosteroids in the stepwise approach. And we're going to talk about long-acting broncho beta agonists and long-acting monoclonal antibodies and some biologic agents and things like that. But it's helpful if you understand the underlying pathophysiology, because then you'll know how these meds are working and at what point. Asthma is not static. It evolves over time with age, and the environment and immune tone also will affect the severity of symptoms. So your job here is to recognize the phenotype, verify it physiologically, and then do something about it, ideally before the remodeling is fixed. Okay, so when we talk about asthma across the lifespan, it's important to recognize that the underlying biology basically remains the same, but the expression of the biology changes with age. The two big pillars are the type 2 inflammation and the airway remodeling. So let me talk about type 2 inflammation. At the molecular level, asthma is driven by Th2 cytokines, that is IL-4, IL-5, and IL-13. These cytokines recruit eosinophils into the airway. That stimulates IgE production by the beta cells, and that increases the bronchial hyperresponsiveness. This is the type 2 high endotype that you see in most children and many adults with allergic asthma. It's the reason why inhaled corticosteroids and biologics that target IL-5 or IL-4 pathways, like, say, Nucala or dupilumab, which is Dupixent, are so effective. These are drugs you see advertised on TV, like, I don't know what the heck they're talking about. Well, here you go. They're IL-5 and IL-4 pathway target immunologics, and that's why they're targeting them. So airway remodeling happens over time due to chronic inflammation and can cause structural changes. The smooth muscle hypertrophy, the goblet cell metaplasia, and the subepithelial fibrosis and epithelial shedding is the process by which the airway gets remodeled. So you think of this like airway stiffening and then narrowing in response to repeated injury. Early on, these changes are reversible, but later they become fixed. And this explains why some adults develop what you call persistent obstruction, even when the inflammation is controlled. Now, in children, it's often viral triggered or allergy driven, and there are smaller airways, so minor swelling causes major reactions. In adults, the remodeling is typically established, and they develop something called neutrophilic asthma, which is less steroid responsive. And if they have occupational exposures like dust and chemicals, that contributes to further airflow obstruction. And then in the elderly, asthma may present as late onset, often with allergic markers, and they will have diminished beta cell responsiveness, beta receptor, rather, responsiveness. And so what happens is they have reduced airway elasticity, and this is how you get that overlapping asthma COPD or COPD cardiovascular overlap. Because why? COPD is the leading cause of right-sided heart failure. So there is your COPD cardiac interplay. Management gets complicated in this situation, though. So while asthma always starts as airway inflammation, what you see clinically based on the patient's age and physiology. So child's asthma flares or an adult airway remodeling or the older adult's dyspnea all share the same inflamed airway root, but they require different approaches because it didn't just happen overnight. So you have to deal with the chronic stress over time. So let's take a look here at this type 2 inflammatory cascade, because this is where the modern biologic therapies get targeted. It starts with the Th2 lymphocyte activation. Allergens, viral infections, and even pollutants can shift the immune system towards this type 2 dominant profile. These activated Th2 helper T cells release cytokines. These are chemical messengers that orchestrate the inflammation that you see in asthma. The key cytokines in this are IL-4, IL-5, IL-13. That's the third time I've repeated them. So each plays a distinct but complementary role in driving disease. IL-4 promotes IgE production, and that further differentiates that Th2 cell component. This connects directly to allergic asthma. IL-4, IgE, allergic asthma, where mast cells degranulate and release histamine after an allergen exposure. IL-5 is the major cytokine for eosinophil activation, recruitment, and survival. It's why IL-5 targeting biologics like, say, Nucala or Syncare or Fasenra, these are like immunologics that are effective against eosinophilic asthma. You're looking for basically a cytokine that targets IL-5. And the one you're going to choose is whichever one's on formulary that day for your patient. So there are many in class. IL-13, this drives airway hyperresponsiveness and mucus hypersecretion, leading to cough and wheeze. So drugs like dupilumab, which is Dupixent, this blocks IL-4 receptors and then targets a dual pathway, which includes IL-13 and IL-4. So together, these cytokines are the things that are sustaining this chronic airway inflammation. And what we're trying to do is be very specific as to which cytokine we're trying to block. And how do you know? Because you can test for these. This is a blood test that tells you which cytokine is active at the time, and that's how you know which one to pick. So this is very directly something you can test and treat very specifically for. Because if you treat the wrong one and it's driven by something else, you're not going to have the effect that you're desiring. So let's take a look now at these structural changes in chronic airway remodeling. So with persistent inflammation, the airway itself begins to change. Goblet cell metaplasia increases mucus production, narrowing the lumen, and smooth muscle hyperplasia and hypertrophy make that airway thicker and more reactive. Basement membranes will also thicken, and subepithelial fibrosis will stiffen the airway wall. Over time, these processes are what makes the asthma less reversible. So that's why early control of the inflammation is crucial. So in type 2 inflammation, it's not just the flare-up, it's the biological engine that's reshaping that airway, and we want to keep that from happening as much as possible. So when you treat asthma today, especially with biologics, you're not just relieving symptoms, you're trying to disrupt that cytokine cascade before it becomes structural and permanent. So asthma doesn't look the same at every age. What's consistent is this triad of airway inflammation, obstruction, and hyperreactivity. But how these appear clinically depends on what age and stage the person is in. So pediatric asthma, in children, for example, you will get the wheezing phenotype. Some transiently have this and then they outgrow it, by the time they're school age, but others will persist. Viral infections like RSV or rhinovirus are the most common triggers in children, and the symptoms tend to be intermittent. Flares up with infection, seasonal exposure. They have family history is often strong. Many children also have eczema co-occurring or allergic rhinitis. About 30 to 50% of this will improve by adolescence. That's what they mean when they say your child may outgrow it. And that's basically due to the immune system maturing. The adult asthma symptoms, these are a little more persistent. They're less episodic. Triggers will multiply. So allergens, exercise, occupational irritants. The majority are atopic with allergic comorbidities like sinusitis or dermatitis, but there is a notable female predominance due to hormonal modulation of inflammation. So by adulthood, many have airway remodeling, which leads to partial irreversibility. Elderly asthma, this is frequently late onset and non-allergic. And comorbidities include things like COPD and heart failure. And that's typically what obscures the diagnosis. Because, oh my, you're in heart failure. The last thing I want to do is give you a beta agonist. But maybe you need a beta agonist because breathing is very important, we've come to learn. So here, there's a fixed obstruction that's common. And there's a perception of dyspnea, which may be reduced. So polypharmacy and drug-drug interactions are also a major factor. Another thing to keep in mind is many elderly are on beta blockers and sedatives, and this complicates the management and can actually flare the symptom. So that's really important to figure out, where did I trigger this? How did I try to help, but really I made it worse? The key thing to take with you here is that asthma expression changes with age. What's viral and reversible in a child might be fibrotic or mixed with COPD as an adult. So always interpret symptoms in terms of the physiological context. So how do we diagnose asthma? Well, the diagnosis hinges on objective demonstration of variable airflow limitations. So what do we need? FEV1 and FVC ratio needs to be less than 0.70. I have 0.75 here if you're going to be generous, but less than 0.70, that is your obstructive criteria. And you need a 12% or better or 200 milliliter or better improvement in the FEV1 post bronchodilator. That is what confirms reversibility. That's the diagnostic indicator for asthma. That's the third time I've said the diagnostic indicator for asthma. So you're going to do something called bronchoprovocation testing. When the baseline spirometry is normal, but the suspicion remains, there's a test you can do called the methylcholine challenge. This used to be done widely. During the pandemic, this test went away because everyone was afraid they'd cause people to spread COVID in the PFTs, and the PFT testing also went away. So it's now making a comeback because we can bill for this here. But suffice it to say, what you're looking for is this challenge is going to give you something less than or equal to 8 milligrams per milliliter, and that indicates airway hyperactivity. Methylcholine is an irritant. And then you breathe it in, and then this is the ratio they get. We're looking for a fractional exhaled nitric oxide. This is a non-invasive marker. So this is something you can breathe out, and you can see how much nitric oxide they're blowing. And there's a ratio as to what it means in children and young adults and adults. Another thing you can do to test for asthma type 2 inflammation is a blood sputum eosinophil. So if you have 300 or greater in the blood, or greater than 3% in the sputum of eosinophils, you can meet criteria for type 2. I don't see this commonly done. The other way you can see this done is that they do a bronchoalveolar lavage. They can get it out that way as well also. You can also do a skin prick or serum IgE test to identify allergen triggers. Total IgE helps determine eligibility for something like omalizumab, Xolair. So this is where you probably have made the referral to pulmonology, but this gives you an idea of where they're headed and what they should expect. And your role is going to be to provide some anticipatory guidance to them. But what we're trying to confirm is not just by symptoms alone, but we're looking for variability and reversibility. That's why we do. Some people will get this advanced testing. All right, so how do PFTs differ over age? Well, we'll often show variable obstruction, and it's normal between episodes, and that's the big takeaway for asthma. If you're not having a flare, it's hard to test for it. So higher reversibility, 15 to 30% improvement in FEV1, that's in pediatric population due to their flexible, non-remodeled, healthy young airways. And the test accuracy is limited by effort and cooperation in very young children. In adults, the classic pattern is this concave expiratory limb on a flow loop. You'll have FEV1 and FEVC of less than 70 with a 12% or 200 milliliter improvement post-bronchodilator. Chronic or undertreated cases may show fixed obstruction due to remodeling. And in the elderly population, you may see a reduced peak flow and increased residual volume from a loss of elasticity, and comorbidities like heart failure and COPD can affect your interpretation. So the stepwise approach for asthma management is this. We're trying to match medication to the underlying mechanism. Is it inflammation, hyperreactivity, or airway remodeling? So inflammation is minimal and episodic. That's typically triggered by allergens, cold, air, viral infections. This is the one that's going to get the short-acting bronchodilator, bronchial agonist, right? So you'll get like, this is the albuterol, essentially, for a rescue inhaler. This targets the bronchoconstrictive component. If you have mild persistent asthma, that is to say, it's not just triggered that's identifiable and you can pre-medicate and treat as needed, but you have mild and it's persistent. Now inflammation is consistent enough for a controller medication, like a low-dose inhaled corticosteroid, like say fluticasone, or budesonide, like Pulmicort, or something like that. This goal is to suppress that type 2 cytokine IL-4, IL-5, IL-13 business. And this is going to reduce that eosinophilic infiltration, because remember, that's the thing that triggers the airway remodeling. So we want to prevent that. Alternatives or add-ons can also include the leukotriene receptor agonists. What's our big one claim to fame? Montelukast. That's the only one we got. And so that's one way to also do that. Cromolyn is a stabilizer of mast cells, so you can do cromolyn. This prevents histamine release. Theophylline used to be in vogue, but a lot of bad things happened, and I'm going to stop talking about theophylline now because we're young enough that we don't have to dig up the past. And then finally, in step 3, we have moderate persistent asthma. This is where inflammation is more entrenched and airway remodeling is underway, and they're going to get higher doses of inhaled corticosteroids. They might get a long-acting broncho beta agonist, something like salmeterol or formoterol. And Advir can be combined with the inhaled corticosteroid, but that's really for the moderate persistent asthma person. Because what's the goal? We're trying to prevent airway remodeling. Now, if they are in severe persistent, these are the people that are getting the biologics. These are the people that are going to be definitely seen in pulmonary, and they're going to get the Xolaires and the Nucalas and the Dupixents and the things like that. The biologics here are trying to specifically target that type 2 inflammation that drives persistent steroid-insensitive asthma. So what are the red flags? Well, ask yourself, has the pathophysiology crossed this threshold into ventilatory failure? If it's severe respiratory distress, they can't speak in complete sentences. This is what's telling you the airflow obstruction and trapping are so significant that tidal volume is being affected. Their SAT is going to be less than 92. They're cyanotic. The chest is silent. This is the 911 to the ER. Hopefully they're on the way to the ER before the chest goes silent, but this is kind of an important finding here. Poor control indicators, these are the things that say if you're needing 2 or more oral steroids within 12 months, failure to achieve control, uncertain about the diagnosis, this is who you're referring to pulmonary. Also, the elderly and the pediatric, multiple comorbidities or multiple ER visits or needing recurrent rescue doses, this is the person that needs a higher level of care. All right. So we are going to talk about these case studies. So pay attention here. We got a pediatric and an adult case presentation. So look at my 7-year-old male with recurrent wheezing. Now, he has a nighttime cough and an exercise-induced wheezing, both classic for early onset allergic asthma. These are episodic, they're not constant, and they're showing that his inflammation is still reversible. So what's going on here with this kid? Well, children predominantly have this Th2-mediated inflammation driven by the cytokines IL-4, IL-5, IL-13. This is leading to IgE production, This is leading to the IgE production and eosinophilic infiltration. So airway remodeling is minimal at this stage. The obstruction is functional and reversible. So it's reflected by this 18% bronchodilator response, and it triggers are often viral or infectious allergens. You'll also see that his FEV₁ percentage is at 76% predicted. This confirms a mild obstruction, and the strong reversibility supports that asthma rather than structural airway disease is the problem. So how do you treat this guy? Low-dose inhaled corticosteroids, to target the cytokine-driven inflammation. He may get a short-acting beta agonist, a spacer. You'll teach him how to use it to improve delivery, especially given the small airways. and you want to teach about the trigger avoidance. And the goal is ultimately to preserve lung function, and hopefully he can outgrow it. Conversely, here we have this 42-year-old female with late onset asthma. She has progressive dyspnea, non-atopic asthma, and occupational exposure, suggesting a more complex but possibly non-allergic inflammatory phenotype here. And in her situation, the inflammation is often marked by mixed eosinophils and neutrophils with airway remodeling that's already present. Late onset asthma involves less reversibility and greater structural change. The smooth muscle hypertrophy, collagen deposition, and the subepithelial fibrosis that typically is seen in these later presentations. Also, an elevated eosinophil can indicate this type 2 endotype. So this will predict a favorable response to inhaled corticosteroids and some biologics that target her IL-5. So what you have here is this FEV at 65%, that's predicted, and it shows moderate obstruction. That's consistent with airway remodeling. There's non-allergic triggers, chemicals, occupational irritants, and the like. And so the management is going to be medium dose inhaled corticosteroids, long-acting beta agonists to provide both anti-inflammatory and long-term bronchodilatory benefit for her. And she may be considered for biologics as well. What we're trying to do for both of these people is we want to reduce the risk of exacerbation, optimize inhaler adherence, and prevent further fixed obstructions. That's the long-term goal. All right. So we're going to go on now to obstructive diseases. What truly defines COPD is not just obstruction. It's irreversible obstruction. Unlike asthma, where the inflammation comes and goes, COPD represents this structural damage that stays. The central question isn't can they breathe today, but rather how much lung architecture has been lost. So how does emphysema differ from chronic bronchitis if both are causing airflow limitations? Well, in emphysema, the destruction happens within the alveoli. The walls rupture, elastic recoil is lost, and small airways collapse on exhalation. The problem is air trapping in emphysema. In chronic bronchitis, the damage is airway centered. So you have chronic irritation, often from smoking. That stimulates the goblet cell hyperplasia and mucus overproduction. The airways are narrow, not from collapse, but from inflammation, mucus, and fibrosis. So emphysema limits gas exchange, while chronic bronchitis limits air flow. So one suffocates essentially from within, and the other clogs from without. You may have heard the phrase, the blue bloaters and the pink puffers. Well, the blue bloaters are your emphysema patients, and your pink puffers are your chronic bronchitis patients. And how do you classify this? Well, there is a GOLD 2024 criteria, and I'll incorporate some of these. This is more in the domain of your primary care course, but suffice it to say, this is how we quantify this. There's a group A, B, and E, and A is low symptoms, and B is high symptoms, and E is risk of exacerbation. So that just gives you an idea. And there's individual criteria and treatment paired with how you do it. That's much like the New York heart failure classification system. There's one for pulmonary conditions. So what actually breaks in the lung with respect to COPD? Well, COPD isn't just obstruction, it's destruction. Two distinct yet overlapping pathophysiologic processes are kind of overlapping here. One destroys the alveoli, that's emphysema, and the other clogs the bronchi, that's chronic bronchitis. So when I say emphysema, what's really happening? It's the enzymatic digestion of the alveolar wall. The lungs' fine lacework of gas exchange is literally unraveling, and the air spaces are enlarging, but they don't exchange gas efficiently. Elastic recoil is lost, and the alveoli can fill, but they can't empty. That's why they get eventually that barrel shaped, balloon shape to their chest, because the chest wall is remodeling to that hyperinflated alveoli. The patient can inhale but can't exhale. It's a balloon that won't deflate. So that's why they'll do things like pursed lip breathing and try to lean forward. What they're trying to do is create back pressure to keep those small airways open. Well, we contrast that with chronic bronchitis. And chronic bronchitis, the small airways are intact, but they're inflamed and they're lined with thick mucus and metaplastic epithelium. So the cough is the body's desperate attempt to try and clear this glue out of their alveoli. In emphysema, the airways are collapsing from within. In chronic bronchitis, they're blocked from without. Both lead to an airflow limitation, but for opposite reasons. Another condition is this protease anti-protease imbalance. So why this destruction occurs? Well, it's an imbalance between protease, that's the enzyme that breaks down tissue, and anti-protease, which is the lungs' defense mechanism. So smoking and chronic inflammation recruit these neutrophils that release elastase and MMPs, and this enzyme that devolves elastin and collagen. Meanwhile, the protective alpha-1 antitrypsin is depleted or inhibited. So in patients with alpha-1 antitrypsin deficiency, the imbalance is genetic. They can develop emphysema in their 30s. Non-smokers with smokers' lungs, essentially. This mechanism explains why the treatment is not just about bronchodilation, it's about slowing that biochemical self-digestion of the lung. Think of this like pancreatitis, where the pancreas is auto-digesting. Well, when you're alpha-1 antitrypsin deficient, the lungs are auto-digesting. That's what's happening here. There's a cellular sequence that ensues. So cellular senescence is the silent accomplice here. Chronic oxidative stress from smoke, pollution, repeated inflammation ages the lung prematurely. And then the DNA damage shortens the telomeres and the repair mechanism fails. And then the macrophages become dysfunctional, lingering in this pro-inflammatory state. COPD is in part accelerated lung aging. It's why two patients of the same chronological age can have lungs that differ by decades with respect to function. Remember, we do that test based on predicted values. Well, if they're well below their predicted value, this could explain why. Now, finally, let's talk about this persistent inflammation bit. This is the most sobering reality. Inflammation that stops responding to corticosteroids. Why? Well, because in advanced COPD, the inflammation shifts from eosinophilic steroid sensitive to neutrophil and macrophage driven, steroid resistant phenotypes. The cytokines involved here are the TNF alpha, IL-8, and reactive oxygen species. These create this vicious self-sustaining cycle of chronic insult and injury. This is why inhaled corticosteroid therapy alone is often not enough in COPD unless there's an eosinophilic component. This disease becomes less about inflammation and more about irreversible remodeling. So when you see a COPD patient, you always have to ask yourself this question: am I treating inflammation or am I managing the fallout of structural loss? If it's inflammation, elevated eosinophils, corticosteroids, and triple therapy may help. But if it's a structure loss, flattened diaphragm, air trapping, low diffuse lung capacity, then bronchodilators and pulmonary rehab is really what this person is going to need. So the major takeaway in COPD is this is not like a single disease. It's an accelerated breakdown of biological balance here. Proteases outruns the anti-protease. Cellular aging outruns repair. Inflammation outruns resolution. And once this balance is lost, the focus then shifts from cure to control, from reversal to slowing the decline and to preservation. So what's left to protect in a lung that's already been burned by time and toxins? That's what COPD management is about. You're trying to preserve what is left. So take a look here. It begins with not with symptoms, but proof of a fixed airway obstruction. So that's why the diagnostic criteria is repeated there. The diagnostic threshold remains if less than 0.7 after bronchodilator use, and that's post bronchodilator use. This tells you that the obstruction is irreversible. That's how you can tell. And that is helping to differentiate COPD from asthma. But spirometry alone is not telling you the whole story. COPD, remember, is a syndrome, and every diagnosis needs to include a why. So we always have to pair this with risk factor history. Smoking, of course, is the classic cause, but it's not the only one. Biomass exposure, air pollution, occupational dust, genetic risk, alpha-1 antitrypsin deficiency, all of those are reasons that someone can have emphysema. So without that context, obstruction could just be a poorly controlled asthma. Once you've confirmed the COPD, the next thing you want to ask is symptoms, exacerbation, and inflammation, because that's the three factors that are guiding your treatment. These Gold 2024 guidelines are designed to help provide you a framework to simplify the treatment process. So this Modified Medical Research Council, MMRC, they have a score, a dyspnea scale score. The COPD assessment, CAT score, is also there. So if the MMRC is greater than 2 and the CAT is greater than 10, that means the patient's COPD is symptomatically significant. These tools are all freely available online. I'm not going to ask you about them on the test, but I want you to know, should you decide to go into pulmonary, this is how these diseases are categorized, classified, measured over time. The major thing you really want to take home from all of this is exacerbation history. That's the strongest predictor of future risk. So if a patient has 2 or more outpatient exacerbations or 1 or more hospitalizations, they are considered high risk. Okay, 0 to 1 mild events means low risk. Okay. Where's my slide? All right, here we go. So, all right. Okay, so how does COPD announce itself? How do you know somebody actually has this thing? Well, rarely there's not a lot of drama. It typically begins quietly. This is someone with a cough and a little breathlessness, maybe some morning sputum. Most patients do not come in and say, I can't breathe. They come in saying, I'm just getting older. And that's the tragedy, because COPD, the earliest clue, you may typically normalize it and not treat it in the person. So you have to be sensitive to that. Early findings begin with things like a morning cough, that so-called smoker's cough. What's really happening here is overnight mucus is accumulating because the cilia are paralyzed by smoke exposure. When the patient wakes up and coughs, it's not a nuisance, it's the only functioning clearance mechanism left for them. Then you might also hear complaints of something like exertional dyspnea. Patients notice that they're winded climbing stairs or walking uphill, but they dismiss it as deconditioning. The physiology is that the small airway obstruction and loss of elastic recoil is leading to air trapping. So exhalation becomes incomplete before the next breath begins. Another thing is this limited sputum production. The early phase of chronic bronchitis reflects a hyperplasia of goblet cells, not yet full-blown mucus and hypersecretion, but a signal of airway irritation and remodeling is what's going on here. Now, some later findings are the barrel chest deformity. That's a direct result of the hyperinflation. The rib cage expands and the diaphragm flattens. It's not just a cosmetic, this is a mechanical disadvantage. The patient now has to work much harder to move less air. Another thing they'll do is this pursed lip breathing. Now, why they do this is because it creates what they call an auto-PEEP, a positive end expiratory pressure that stents open the collapsing bronchioles during exhalation. It's almost an instinctive thing they do. Nobody teaches them how to do it. The body kind of invents its own ventilator. because the body is trying to survive. Another thing you might notice in a late stage is the use of accessory muscles at rest. What you're looking for is the sternocleidomastoid and the scalene muscles. These are evidence that the diaphragm has basically lost its dome shape and power, and we're trying to use anything else to move that chest wall in order to get air in, right? We need to create a negative pressure so air can push in and fill us up. Another late sign is cor pulmonale. I've mentioned this several times, but chronic hypoxia causes pulmonary vasoconstriction, and that's what leads to the right-sided heart strain. So you may see things like JVD, hepatomegaly, ankle edema, but remember, this isn't heart failure from the left. This is pressure overload from the lungs. Now, the physical exam, what does it sound like? You will hear decreased breath sounds with the stethoscope, not because they're not breathing, but because there's less air movement. Remember, it's trapped. So they're trying to breathe through destroyed alveoli. And there's also a prolonged expiratory phase. And this is diagnostic in itself because the patient's lungs have become a reservoir of trapped air. And you also may or may not hear wheezing. It may come and go depending on mucus and how open the airway is. The absence does not rule out obstruction. The other thing that most people don't do is tapping on the chest, but you will hear, or say the EA sound, egophony, you'll hear hyperresonance to percussion or a hollow drum tone where air parenchyma should be. There's not. So age-related considerations with the older adults. So this is why we get full, because many will attribute the breathlessness or the age to reduced social or physical stamina, getting old, and they may delay it. Other things to pay attention to, because there are comorbidities that can overlap, are things like heart failure, anemia, obesity. All of that can mask or mimic COPD symptoms. So remember, normal chest x-ray does not rule it out. You have to do spirometry. And if you have COPD in someone that's 40 years old or younger, this should raise a red flag to you for alpha-1 antitrypsin deficiency. Always test, especially if they're a non-smoker with emphysematous changes on the imaging. So when you examine a patient, you need to look for the story behind their symptoms. The cough is compensation. The dyspnea, that's air trapping. The posture, that's self-ventilation with the pursed lips. The quiet chest, that's collapse of alveoli. It's not all as well. So every finding reflects a core process. Airflow obstruction can lead to gas exchange inefficiency. And what is benign inflammation can end in this architectural failure at each stage. And each stage you have a chance to intervene, but you need to know what you're doing. Okay. This is just a chart of the GOLD criteria with respect to COPT patterns and interpretation. And you can obviously, the more FEV percentage retained, the milder, and the less that's retained, the more severe the condition is. That's all this chart is showing here. Just remember, asthma and COPD can look identical on a flow volume loop, but the trick is FEV₁ improves by less than 12% after a bronchodilator. That's what suggests the irreversible nature, and we call that COPD. The improvement is less than 12%. That means that it's not reversible. If it improves by more than 12%, that's what we think is asthma. That is reversible. Okay. So ask yourself, is the obstruction fixed or reversible? Is the primary airway inflammation, or is it alveolar destruction? Does the physiology align with the patient's phenotype? And then depending on the number, you'll figure out where they are. I'm not going to ask you to stratify someone according to Gold's criteria. That's too specific, but you should just know that there's objective criteria in the field that they use to quantify severity. The PFT is going to quantify what the body already knows, that the gas exchange is a privilege of structure. So if the structure fails, gas exchange to follow. Okay, so let's look at some risk factors and modifications that we can do. If COPD is largely irreversible, then what do you need? Where do you find your leverage to help the patient? We find it upstream in the causes, not the consequences. So this slide is here to remind you that the most powerful intervention is not the inhaler and the steroid, it's the behavioral, environmental factors that you can modify, and let's walk through them here. So smoking cessation is the single most effective therapy because it halts the insult. Every puff recruits a neutrophil, floods the lung with a reactive oxygen species, and drives this protease-antiprotease imbalance that's destroying alveolar walls. So when the patient stops smoking, inflammation doesn't vanish, but that cascade slows dramatically. That's why they'll get some improvement. Longitudinal studies show that if you quit smoking, you can stabilize that FEV₁ decline, sometimes just within months. No pharmacologic agent can do that much. That's how important encouraging cessation is. And you can do the behavioral counseling, nicotine replacement, bupropion, Banseril, et cetera, et cetera. But that's generally how we try to go after it. It's a behavior modification. So, and if they relapse, we don't want to judge, just relapse. That relapse is part of the recovery process. Okay. Now, let's look at this alpha-1 antitrypsin screening. Who do you screen and why does it matter? Because in some patients, COPD is not earned, it's inherited, essentially. And alpha-1 antitrypsin deficiency leaves the lungs unprotected from neutrophil elastase. Now, this results in this early onset of emphysema, often in the 30s or 40s. Now, you screen when you see COPD in a non-smoker under 40 or 45, family history of emphysema or liver disease, basilar predominant emphysema on imaging. That's the classical sign. You see it more in the lung bases. And a positive result will warrant a referral because this treatment needs to be augmented by pulmonary because they're going to need some biologics here. But your job in catching it is great because now you can start the thing that prevents the alveolar destruction and decline. So when you think COPD management, you have to ask yourself, am I prescribing inhalers to compensate for ongoing injury, or am I stopping the injury itself? That's the mental shift that needs to happen. Because the bronchodilators, they're going to feel better, but it's only risk factor modification that alters it. And the worst thing I want them to do is to suck on the albuterol and then puff a cigarette to get that smoke nice and deep in the lungs. So we don't want to do that. But some people will do both. Okay. So once you've diagnosed COPD, how do you decide where to start and when to escalate? Well, the GOLD 2024 guidelines give you a little roadmap. It's not just about the inhalers, it's about matching the mechanism. So ask yourself the question, how symptomatic are they? That's the MMRC or the CAT score. That gives you how symptomatic they are. How many exacerbations and hospitalizations have they had? That changes everything. What is their blood eosinophil count? It predicts who will benefit from steroids. And do the symptoms reflect airway collapse, inflammation, or both? That's how you stratify on that GOLD ABE framework. So forget the old ABCD. Now you're doing GOLD 2024, and that's how you're essentially stratifying them. And you have many bronchodilator options to choose from, and inhaled corticosteroids, not everyone from COPD will benefit from them. In fact, if you overprescribe the inhaled corticosteroid with an eosinophilic inflammatory condition, you can, that's who should get it rather. The inhaled corticosteroids are for those with the eosinophil inflammatory signature. If they don't have that, the risk of too much inhaled steroid is it can increase the risk of developing pneumonia. So that's what the conundrum becomes. So can you ever stop the inhaled corticosteroid once you start it? Yeah, you can actually, if the patient has no recent exacerbations or develops a recurrent pneumonia. And that's how you figure out who to stop. And sometimes you have to wean it if they've been on it a long time. All right, acute exacerbation. So when the patient calls and tells you they're short of breath, how do you tell if it's a bad day or an exacerbation? This is when you recognize what the daily functioning looks like. So acute exacerbation is defined by sudden worsening of dyspnea, sputum volume, or purulence. beyond the patient's usual baseline. So if it's a flare of an airway inflammation or mucus production, that is the you need to go. This is not just you're having a bad day. And antibiotics are indicated if they have more than 2 of the following: sputum purulence, increased sputum volume, or increased dyspnea. Okay. Failure to response is the refer to the ER. All right, so when do you manage in primary care versus when you refer? For most patients, the gold stage 1, 2, that's fine in the community. Stable symptoms, standard therapy, follow-up spirometry for monitoring, and they're doing the smoking cessation, standard vaccinations. That's good primary care stuff. The hospital referral is the frequency of exacerbations, well, not hospital, but specialist referral. And also if they have an alpha-1 antitrypsin deficiency, or they need oxygen or non-invasive ventilation, those are the ones that get referred. All right, let's take a look now at some pulmonary acute conditions besides COPD and asthma. These are some of the bread and butter conditions that will make up who you will treat. Do we need a 5-minute break? Thoughts? Why don't we do a 5-minute break? Oh, did it break? It did. Okay, well, I broke the recording. That's okay. We'll upload both modules. So what we have now that we're going to talk about are these acute conditions that affect the pulmonary system. So pneumonia is the first and most common. This is an inflammatory disruption. Pneumonia is not simply an infection. This is basically alveolar inflammation that replaces air with exudate. So when pathogens reach the alveoli, macrophages will initiate an immune cascade that releases cytokines that recruit neutrophils. So this immune cells flood the alveolar space, and that produces the capillary leakage and the edema and thickening of the alveolar membrane. So what happens as a result is gas diffusion becomes impaired because oxygen must now move through fluid and cellular debris instead of that thin micron distance dry membrane. And this affects lung segments because they become consolidated, like a solid sponge instead of this air-filled sac. And this is what creates that ventilation perfusion mismatch. And blood flow persists, but ventilation is lost because the airway is essentially blocked by the inflammation. So systematically, inflammatory mediators are entering circulation. They generate the fever response and tachycardia. Sometimes it can lead to sepsis. And then what you're doing is you're thinking of pneumonia as an oxygen diffusion problem caused by some inflammatory barrier. There's another condition here, the pneumothorax. This is mechanical collapse. The pneumothorax, by contrast, is mechanical failure of the pleural cavity. So normally a negative pressure in the pleural space is what keeps that lung inflated up against the chest wall. When you inhale, that's a passive thing. You just create a negative pressure in the chest, and the atmosphere is trying to kill you, so it rushes into your lungs. You quickly make that positive, and so you don't die. So when air leaks into the space, through, say, trauma or spontaneous rupture of an emphysema bleb, like a ruptured alveoli, that causes the negative pressure to equalize. We don't want that. And then the lung will recoil inward and collapse partially or completely while the chest wall is springing outwards. So in a tension pneumothorax, air continues to accumulate with each breath, compressing the mediastinum and impairing venous return to the heart. So oxygenation fails not from inflammation in this case, but it's failing from a loss of alveolar surface area and decreased compliance because that lung is now collapsed. Both of these conditions, pneumonia and pneumothorax, reduce effective alveolar participation in gas exchange, but different reasons. One, the alveoli is filled up, and the other, it's empty. Pneumonia is increasing alveolar content, fluid, cells, etc. Pneumothorax is increasing pleural content, air. In both conditions, the body responds with tachypnea and sympathetic activation and hypoxemia, and that signals the same emergency, but from two different origins. Okay. So, about to sneeze. Pneumonia begins as a breach of the lower respiratory defenses. So when you say pneumonia, that's the distinguishing criteria. That's a lower pulmonary infection rather than, say, an upper respiratory infection. Now, normally the lungs, they maintain sterility through ciliary motion and mucus clearance and immune surveillance. When those barriers fail through, say, aspiration, inhalation, pathogens will adhere to the respiratory epithelium, and that triggers the inflammatory cascade. Once inside, the alveolar macrophages are the first responders. These are releasing cytokines like IL-1 and TNF-alpha. And what happens is these are going to start to recruit neutrophils to the alveoli. And these neutrophils will release an enzyme, reactive oxygen species, which destroys the pathogens, but also it damages the alveolar capillary barrier in the process. This is what produces that capillary leak of a protein-rich edema that floods the alveoli. And then what happens is that exudate accumulates, the once filled air sac becomes dense, leading to consolidation. The surrounding lung tissue remains perfused, but is no longer ventilated, and that's what creates a shunt. So blood will pass through unoxygenated. That's why you will see hypoxia in your patient with pneumonia, hypoxemia to be more specific and correct. Now, there are different pathogens that provoke similar inflammatory patterns, but with varying degrees of intensity. So things like strep pneumoniae typically will cause lobar consolidation. Mycoplasma or viral agents typically cause diffuse interstitial inflammation. And Legionella and chlamydia often will create a multilobar or an atypical presentation. Now, those phrases you're hearing me say, lobar consolidation, diffuse interstitial inflammation, or multilobar atypical, those are what you're going to see in your X-ray reports. So this is what they're trying to communicate to you. They obviously cannot tell you the bug because it's not a culture, but now you know what these bugs are correlating with what radiologic findings. In all cases, the core dysfunction is the same, though. You have a disrupted gas exchange caused by an inflamed alveolar membrane and impaired ventilation perfusion balance. So community-acquired pneumonia, from a pathophysiologic lens, this centers on diagnosing and confirming inflammatory consolidation within the alveoli. So there's a clinical triad here that you should notice. It is fever, cough, and focal crackles. These signal localized alveolar filling. So a chest X-ray is going to reveal this consolidation, which translates that microscopic process of exudate accumulation into some sort of visible density you can see on the X-ray. That density represents the alveoli filled with inflammatory debris rather than air. In evaluating outpatient eligibility, what you're looking for here, though, is not to focus on the treatment, but their physiologic reserve. In other words, what you're trying to figure out is, can the patient maintain adequate oxygenation and hydration without needing to admit them? And so there are various tools to help you quantify this sort of thing. And you're looking for things like signs of systemic stress, tachypnea, hypotension, confusion, etc. If you have all of those signs of widespread inflammation and a huge oxygen debt, obviously you can't manage them in the community. The broader goal is you need to distinguish, is this localized or systemic? Community-acquired pneumonia that overwhelms the compensatory mechanisms, that's what requires more acute care. But if they have good reserve and they're compensating, you can manage in the community. Okay, So empiric treatment for community-acquired pneumonia. This is an overview of the medication and duration, but basically amoxicillin TID or doxy. This is more for your primary care course, but I want you to see how this plays out. Community-acquired hospitalization criteria. There are various scores that you can use here. So if you work in an ER or an urgent care, this helps you determine based on these various scoring criteria, pneumonia severity index or the curve score, to figure out where should this patient best be managed. But at the end of the day, it's going to be physiologic reserve, stability of the vital signs, and compensatory mechanisms. Pneumothorax. So pneumothorax is a pressure problem. It's not an oxygen problem, not at least when it begins. This occurs when air breaches the pleural cavity, equalizing normally negative intrapleural pressures with atmospheric pressure. So the loss of that negative gradient that causes the lung to recoil inward, collapsing into varying degrees depending on the size and rate of air accumulation. This collapse will immediately reduce the functional alveolar surface area. That's what's impairing the ventilation and decreases compliance. The severity of gas exchange disruption depends on how fast the air enters and whether the underlying lung is healthy or already diseased. We can categorize pneumothoraces by their underlying mechanism, though. So you can have a primary spontaneous pneumothorax that occurs in people without known lung disease, often tall, thin, young adults with subpleural blebs. Think small, fragile alveolar outpouchings near the lung apex. These blebs will rupture due to differences in alveolar pressure or wall tension. But despite being spontaneous, these are really structural weaknesses that interact with mechanical stress. So a tall, thin, lanky swimmer holding his breath diving deep may be one that develops a spontaneous pneumo. You can have secondary spontaneous pneumothorax, and this occurs in patients with pre-existing lung disease like COPD, asthma, cystic fibrosis, interstitial lung disease. Here, the lung is already compromised. The alveoli are hyperinflated or fibrotic, and rupture occurs in tissue with poor recoil. The impact is greater, though, because baseline gas exchange is already reduced. You can also have a traumatic pneumothorax, and this results from direct injury. Could be a penetrating trauma, a rib fracture, some sort of iatrogenic cause like a central line placement where you drop the chest, barotrauma from mechanical ventilation. That's what happens when you try to ventilate according to actual body weight. The key concept here is that air is forced into a space that cannot release it. Another one you can develop is a tension pneumothorax, and this represents an extreme form. This is where air enters the pleural space but can't exit, and it creates a one-way valve, and this generates that increased rising intrathoracic pressure, and the mediastinum will shift and compress the opposite lung and vena cava and reduce venous return and can cause obstructive shock and cardiovascular collapse. So at every level, the core dysfunction is a loss of pressure equilibrium, and that thin margin of normalcy has been violated. The upshot of all this, the treatment for all of this, is a chest tube. You can work out the cause later. So how do they present? Well, the clinical presentation will mimic the mechanic of the collapse. So when the pleural cavity fills with air, the patient will experience a sudden loss of functional lung volumes. This is perceived as a sharp pleuritic chest pain and abrupt dyspnea, especially on inspiration when the lung attempts to expand against that trapped air. And some physical signs and symptoms you'll see will correspond with what's going on. So if you have asymmetric chest expansion, say one side moves less because that lung side has lost compliance, or you may see hyperresonance where air replaces lung tissue beneath the chest wall, or you may appreciate diminished or absent breath sounds. Air in the pleural space blocks transmission of breath sounds from the lung parenchyma. That's a tension pneumothorax, which adds systemic findings. So tachycardia, hypotension, distended neck veins, tracheal deviation. Each one is reflecting that shift of the mediastinum and compression of the great vessels. So from a physiologic standpoint, this is obstructive shock masquerading as a pulmonary problem. The longer this goes on, the more venous return and cardiac output will fall and produce profound hypoxia. So the essential concepts you need to take home from this is even before intervention is to recognize that there is an underlying failure in mechanics and the alveoli may still be intact. It's the pleural space that has failed. Okay. So we know pulmonary lecture would be complete unless we talk about ARDS, adult respiratory distress syndrome, and this represents that final common pathway of severe inflammatory injury to the lungs. So regardless of the initiating event, whether the insult originates from, like, say, the lung, pneumonia, aspiration, or systemically, say, from sepsis or pancreatitis, or the result is the same. What you have here is diffuse alveolar damage and catastrophic loss of the lung's barrier function. So for a nurse practitioner, the goal is not to manage the ventilator settings. It's to recognize the physiologic warning signs early. So a patient who is, say, tachypnic but oxygenating adequately now requires escalating amounts of oxygen. That's a trend you observe. Or breath sounds become diffuse and crackly, not focal, like pneumonia. Or the chest x-ray shows bilateral opacities that don't fit a lobar pattern. So by understanding what's going on here, you'll know that ARDS is not about fluid overload. It's about inflammatory capillary leaking, a non-cardiogenic pulmonary edema. Early recognition is essential. This person belongs in the ICU. So what's going on here with ARDS? So at the microscopic level, you have diffuse alveolar damage, and this is the hallmark of ARDS. The alveolar capillary membrane has become inflamed and permeable. That's allowing protein-rich fluid to flood the alveoli. This is known as the capillary leak. This transforms that air-filled space into a heavy fluid-laden sac. And the blood's immune system amplifies that injury. So neutrophils and cytokines are starting to flood the lungs, and you're releasing oxidants and enzymes that damage the epithelial and endothelial surfaces. This is setting up a vicious cycle of more inflammation, and it leads to more leak and more hypoxia. The next thing that happens is that surfactant dysfunction. So this follows, and as a thin phospholipid layer that keeps the alveoli open gets disrupted, without that phospholipid layer, the alveoli collapses at end expiration, which reduces compliance and worsens oxygen diffusion. So hang on to that. Alveoli are collapsing at end expiration. End expiration. That means we want to do something to keep it open with end expiration. There is a diagnostic criteria called the Berlin criteria from 2012. It's a formal process. Basically, the criteria includes onset within 1 week of a known insult, bilateral opacities imaging not explained by effusion or collapse, respiratory failure not due to a cardiac cause, and a PaO2-FiO2 ratio of less than 300 to grade severity. In short, that is the ARDS diagnostic criteria. It's an inflammatory drowning of the lungs, not from excess fluid intake, but from the body's own immune storm. So clinically, it unfolds very rapidly, usually within hours to a few days after the triggering insult. So patients with severe dyspnea, tachypnea greater than 30, hypoxemia that doesn't improve with supplemental oxygen, and this refractory hypoxemia is the key thing. It's what distinguishes ARDS from pneumonia and CHF. When you give pneumonia CHF oxygen, they get better. The O2 goes up. In ARDS, it does not. That's the key thing. So on imaging, what you'll see is this diffuse bilateral infiltrates, and that's representing the alveolar flooding rather than focal consolidation. Mechanically, the lungs become stiff and the compliance plummets, meaning each breath requires more effort. As a result, patients will appear visibly fatigued. You'll say the work of breathing has gone up. They start using accessory muscles just to ventilate. And this is a huge risk factor because they're going to get too tired to breathe. So you want to intervene sooner than later in these patients. Direct lung injury like pneumonia, aspiration, pulmonary contusion, or inhalation injury can be a risk factor for this. So if they have any of those conditions, that can set the stage. You can also have indirect injuries, sepsis, pancreatitis, major trauma, massive transfusion conditions. These are things, anything that sets off that inflammatory response cascade and it causes it to spill into the lungs. Regardless of the cause of the ARDS, the same pathology is happening. It's capillary leak, inflammation, alveolar collapse. So recognizing that profile, knowing that they have these risk factors is what will allow you to intervene. So ARDS is suspected if you have acute onset dyspnea less than 7 days from the insult, hypoxemia unresponsive to oxygen, and bilateral opacities on imaging, especially in the setting of known insulting risk factors such as sepsis, trauma, aspiration. Pathophysiologically, this is the point where the alveolar flooding and shunt physiology become dominant. The lungs here are perfused, but they're not ventilated. Oxygen cannot cross the thickened fluid-filled barrier. ARDS is like a progressive cascade, okay? Endothelial injury, alveolar flooding, refractory hypoxemia, respiratory failure. Recognizing where the patient is in the cascade, that's going to help determine what you can do to help. Okay. So let's bring this all home now. So across all age groups, the core pathophysiologic mechanism of ventilation, perfusion mismatch, diffusion impairment, and altered compliance are the constants. And what changes is the physiologic reserve and the compensatory capacity. So in pediatric patients, they are relying heavily on diaphragmatic breathing, and they have smaller airways, which makes them more vulnerable to obstruction and fatigue. Even mild inflammation or mucus can drastically reduce their airflow. So their alveolar surface area is still developing, so gas exchange deficits can escalate very quickly. In adults, they possess mature pulmonary mechanics and they have the greatest homeostatic resilience. So here, the disease often reflects some sort of lifestyle exposure, smoking, occupational hazard, infection, rather than some anatomic limitation. In the geriatric population, however, they lose elastic recoil and the chest wall compliance is diminished. The ciliary function goes down, the reduced mucociliary clearance is reduced. The result is increased susceptibility to pneumonia, aspiration, hypoventilation from even the slightest physiologic insult. And in pregnancy, respiratory physiology adapts in order to support that fetal oxygenation. So tidal volume and minute ventilation increase, but residual volume decreases due to diaphragmatic elevation. And any compromise like asthma exacerbation or pneumonia is going to accelerate that maternal fetal consequence because now we're really at a deficit working behind an already diminished state. So what does a stable outpatient COPD patient come across into acute care? How do you apply this reasoning to, say, a pregnant patient with asthma or an older adult? What referral criteria are you going to use to know I need to move you to the next level of care? Well, let's figure this out. So here are the pregnancy respiratory red flags. This imposes, the respiratory rate greater than 30, the saturation less than 95, the inability to complete sentences, and the respiratory symptoms with fever, hemoptysis, or cyanosis. These are all red flags. On the left side there, those are all normal physiologic adaptations. In the geriatric population, you will notice this reduced elastic recoil, increased risk of respiratory adverse events, and the polypharmacy. These are all the complicating factors that make a geriatric patient difficult and requiring special attention. And in the pediatric population, infants 0 to 12, if they have a respiratory rate of greater than 60 breaths a minute with severe or severe retractions, hypoxemia less than 92%, or an inability to feed due to distress, that's your red flag in infants. In toddlers, breathing should not be noisy. So if you're hearing stridors or persistent wheezing or prematurity with recurrent hospitalizations, those are all red flags that you can elicit in the history. School-age children, exercise-induced symptoms, limiting activity, poorly controlled asthma, needing 2 or more ER visits in 6 months, and suspected foreign body aspiration, hemoptysis, and chronic cough for 4 weeks. All of those require referral and elevation. All right, let's look at these case studies here to integrate all of this. So shortness of breath means something very different depending on your age and stage. So let's start off with this 5-year-old with fever, tachypnea, and retractions. The chest x-ray shows a right lower lobe infiltrate. You have an oxygen saturation of 94% on room air. At first glance, this saturation looks okay, it's fine, it's greater than 92, I'm fine. But in pediatric, the context matters more. So the increased work of breathing and the borderline oxygen saturation is what tells you that this kid is using accessory muscles to maintain that gas exchange. They're not stable. They're compensating, and children can commonly compensate, but for so long, and then they precipitously crash. So even without severe hypoxia, this combination is meeting the threshold for a hospital referral. Because this key principle here is that higher metabolic rate, lower reserve, faster deterioration. So always intervene earlier in kids than you think you need to. When you're dealing with a pregnant woman, you have here a 28-year-old, 32-week pregnant woman who presents with acute dyspnea and right-sided chest pain. She's got tachycardia and she's afebrile. The oxygen saturation is 95%. This is a classic diagnostic trap because the normal vital signs don't rule her out of danger with respect to this pregnancy. So she will have an elevated D-dimer and a hypercoagulable state. The differential immediately shifts in her to a pulmonary embolism. The physiologic changes of pregnancy reduce this functional reserve capacity and increased oxygen demand. So the slightest emboli can destabilize very quickly here. So this is an immediate referral to the ER because of pregnancy, dyspnea plus chest pain. It equals PE until proven otherwise. Dyspnea, chest pain in pregnancy, PE until proven otherwise. And finally, you've got this 78-year-old with COPD who presents with mild increased wheezes and sputum, but stable vitals and oxygen at their baseline. So this is mild exacerbation. This is appropriate for outpatient management, assuming they have a reliable support and access to follow-up care. What you're noting here is that stability means in the elderly, you have to pay attention because they can have a blunted symptom perception. They don't quite understand how severe they are, meaning they tend to underreport. Also, men tend to underreport. So their comorbidities and medications, you look at their beta blockers, sedatives, inhaled corticosteroids, all of that can complicate. So you want to clean that up as much as possible. The decision here is not just based on the numbers, but you're looking at a functional assessment. Can they manage at home safely? In older adults, the question isn't only how sick are they, it's how supported are they? So you will see this whole lifespan decision-making framework. This is the mental model you need to carry with you. Pediatrics, low reserve, fast decline, intervene early. Pregnancy, physiologic changes, mask pathology, err on the side of escalation. Geriatrics, adaptation happens chronically. There's multiple variables, context matters. The big thing you need to decide is it just the symptom? And what's the system behind it? All right, finished 10 minutes early. Look at that. I'm going to stop the recording here.